Juyong Lee. We will take the first start the first session. So
we are live. We are live now.
Okay.
Okay, so we start this session. Maybe we will have a welcoming speech from Toshi.
Yes.
Toshi, do you want to have a 2 minutes welcoming speech?
Yeah, good afternoon. That we're going to have a third webinar of with the help of some IVAS members from Europe. We will have 6 talks in the first session, 7 talks in the second session, which all talk about the Carpal mechanics, path mechanics. Then we will enjoy this webinar. Thank you.
Good morning.
Okay, we start, and so we start from PC. PC is a founding of the APWA, and he will give us a talk about mini invasive management for scaphoid and union. PC, please. PC, we cannot hear you.
我就上那草丛上听没事吧？能听到吗？
过点了。
没有吗？能了哈。
老老人来。
Can you see the screen now?
Yeah, yeah, it's great.
Yes, it's okay. Go ahead.
Okay, let me start again. So thank you very much, everyone. It's always my great pleasure to be able to speak at this special APWA webinar. So I started the talk about the minimal invasive management of the scaphoid non-union, the state of the art. I think the scaphoid fracture management is strange. Sorry, the screen is a bit strange. Let me restart. Sorry, I don't know what's happened. I stop share and then I restart. Okay, hope this time is all right. Okay, that's better. Yeah, I think the principle of scaphoid non-union surgery has been well established, and then as presented by Dr. Nagel, I think some principle, we have to surgically manage a cervical non-union. We need to correct the malalignment, have the adequate debridement, exposure of the fracture site, and then good bone grafting and stabilization. I think that sort of principle actually governs so far on the scaphoid non-union surgery. But of course, most of the time in the past, we are talking about open surgery. But actually described by Tim Davies and his team that in a very big meta-analysis of about more than 140 studies involving 5,000 more cases, actually they have defined that in fact globally there are no difference between the union rate of those cases treated with a non-vascular bone graft and vascular bone graft. And in the presence of the AVN, there may be some difference between the vascular bone graft, which is actually can help in 74% of patients of the union. So, but as he has just see this paper or this important study by our good friend Scott Wolf, actually did a very meticulous study on these 35 patients of non-unions with all sort of evidence looking at the vascularity from MRI, intraoperative bleeding, and even histological analysis. Actually found that even in this cohort of patients with more than 50% of patients has evidence of ischemia, but in fact, just by simple cancerous bone graft and screw fixation, they can achieve union in 33 out of 35 in 12 weeks. So to him, actually, this regard of the vascularity of the proximal pole may be a good fixation, good bone graft can already heal most of this non-union. I think that is actually very important scientific support to the concept of the minimal invasive surgery. Because if you can actually perform this even in less invasive way, you have least disturbance to the biological environment, the ligament, the vascularity, you can have actually a much better chance to get a very nice union. Not only the union of the bone, but also an improvement in the functional outcome of the patient. The arthroscopic bone graft concept, I believe it started in my hospital back in 1997. This series actually in the first 20 years have managed around 128 risks with the median follow-up of 26 months. In fact, we can achieve an over union about 89%. There's still, of course, like every series, there's still some failure, but not all the cases will require revision surgery. And we have tried to analyze our different factors which may affect the union, but ultimately only one factor will affect the union, and that is the proximal fragment bleeding. If intraoperatively you can see poor bleeding, no matter how much we deblide, we have a less chance of union, but still got around close to 80% of union chance, which is not bad. But if we can actually see a very nice bleeding from the proximal pole, basically you have a very high chance of union, over 90%. So I think that is the only significant factor. Timing is not the issue. This is case we managed 27 years age of non-union, not very good blood supply of proximal pole, but with adequate debridement and bone grafting and fixation, no problem to achieve very uneventful union and also a correction of the collapse. This another case, even more significant, 40 years non-union and with a history of gouty arthritis. So interestingly, even after 40 years, although we see a very mobile non-union, but the articular surface can still be quite good, although there's also evidence of some sort of gouty arthritis present. And the non-union is very, very sclerotic, but no problem. With patient, you can debride the bone until you can see bleeding. So after 40, you can still have the bleeding. What we need to do is just to put the bone into a nice fixation and adequate bone graft and pack it. And there's no way, no problem to achieve a good bone contact and put a bone union. And even after almost 10 years of time, there's a definite evidence of union, although in this patient, they're also perhaps because of gouty arthritis, they also end up into some sort of partial wrist fusion, but no problem. Patient no pain, still enjoying very good function. So over the past decade, actually the ABG is utilized much more widely. Thanks to Jeff Koo, actually found that there's actually many publications and many centers already practicing this. And in terms of the number of publication, there's also an increasing trend. So see in our home country in China, actually Dr. Bo Liu, actually in Beijing, they performed 70 cases, all 100% union. And in the south, in the Shenzhen area, between 2013 and 2017, 25 cases in Dr. Zhao Ji's center, all united. And then Dr. Tang, one of the earliest hospital in China practices 30 cases, all united. How about in Japan? Actually, Professor Tsubogawa is another pioneer in Japan, utilizing this concept and published paper as early as 2009. He used a little bit different method from mine, but actually also achieved very good result in many different types of the skill. In Korea, recently, actually one of the earliest practiced bone graft back to 2008. And you can see a very high union of 97.7% cases, and within a short union time of around 2 months. Subsequently, many people from Korea also published, including Troy. Actually, one of the important work is to compare the outcome between the bone graft and open. Actually, they show that there's no difference in union rate, both and achieving high union. Although in the APG group, there's a little less correction of the Carpal, but there's no clinical signal. In the Taiwan group, Dr. Shi has actually also practiced as early as in 2006, and he did it in this type 1 into type 3 type of non-union with no proximal ABN. He harvested bone graft from either disoriented or either crest, achieved also a very good outcome in union of 88.6%, similar union rate. And a good friend, Jupan Wang and Yi Chao, actually I think Dr. Wang will also present some of his experience later on. They're also in the latest series, also very good correction, even in the patient with unstable non-union. There's no problem correcting the alignment back to more to normal and just from the iliolateral radius. Over our friends in the European country, in France, Professor Madeline has actually performed a very good result using distal rectus as the donor site, achieved very good union. Only 1 out of the 35 cases failed to unite it, and there's also achieved very good, excellent functional outcome and grip strength. Dr. Cognac in Paris also performed published papers in 2017. Again, he using this sort of detrify marrow biopsy needle, just taken from the distal rectus, very minimum invasive technique, and achieved 100% union in all of the 23 cases. In Iran, Dr. Volar also performed 70 cases, 100% union. In Spain, Dr. Pedro also performed 13 cases, 100% union, using this sort of trick, using an insulin syringe to inject the bone graft into the joint as a very good trick to perform this type of surgery. In Norway, Dr. Rico also performed this type of surgery with 100% union. In Denmark, Dr. Novik compared the APG with the percutaneous fixation and found that although the APG take a little bit longer time, but they heal faster. The healing time is amazingly early, 7.8 weeks versus 10.5 weeks. Finally, in Australia, Jeff Edgar did a great job here. Actually, tried to compare the Russell bone graft on the medial femoral condyle. Actually, compared to that, there's a short operating time by 33%, but achieved similar range of motion and union time. And in fact, the union rate is very high. And there's tricks to convert the KY into the screw at about 6 weeks of time. Very good tricks onto that. So overall, I think that in the future, we were just talking about more accurate assessment in the surgery. Actually, people have been using the 3D tracking system as a navigation to help to do a more accurate surgery, and also intraoperatively using intraarticular ultrasound to look at the carpal vascularity. Professor Wendell using the 3D pinning technique to do a very precise and even very minimally invasive surgery to the scaphoid non-union situation. Thanks for Wendell's slide. I think he will talk a little bit more about this topic later on as a more elaboration. And in Hong Kong side, actually my colleagues, Dr. Mac, he had been using the 3D panning technique to correct even malunion in a very precise manner, combined with the intraoperative navigation guide control and achieve very good reduction and correction. Again, Dr. Mac will describe this technique in more detail in the second section. Our chairman, Dr. Bollier, is a very amazing using the locally designed robot to assist in the very precise fixation in the scaphoid non-union. Again, this will be the trend to go because this will actually much improve the accuracy of the surgery in the near future. Healing agents also help. You can actually using our other artificial agent to help healing like the BMP2. Also using the stem cell can actually help this healing. Like actually the BMP2 has been first promoted by Dr. Neil Jones in 2005, but there's not been recognition. But using BMP2 concept, you can using abdomen into the arthroscopic manner, but even you can avoid the using of the autogenous bone grafting site. And by using this, you can completely perform the surgery totally under local anesthesia, under perfect direct vision and control, and to fill up the space with the BMP2, with adequate fixation. And you can actually see that this patient also can heal very quickly with also excellent clinical function. And I'm sure that Dr. Toshi Nakamura will going to share more experience about the BMP2 in the subsequent talk later on. So this is a case with a 10 years of non-union symptom of 3 years. And you can actually see that actually the scapula capite is very athletic, but the patient is not old, so we decided to perform the APG, but at the same time, inject mesenchymal stem. Not only the fracture heal, but actually the heal a lot, and the patient has excellent clinical function without any pain. So I think that's another way to open up the future. So ladies and gentlemen, I think actually earlier this year, I also gone through a very interesting talk in the Australian Hand Society that talk about has arthroscopic bone graft and fixation make open grafting and vascular bone graft almost obsolete. I think we almost can come to a conclusion that I have a conclusion that after the 24 years of practice, I have a feeling that APG perhaps will be the universal solution for scaphoid non-union, despite all occasions. And there's already some evidence now. So last but not least, I would like to welcome all of you to join the meeting in Hong Kong. This year, we will have our annual meeting, the workshop and webinar in December. we have a very good overseas speaker panels together with a local speaker. So I hope they will be bringing some sort of new information, excitement to all of you. Finally, thank you for all the kind invitation. We are continuing to see the growth of the APWA, and with your continued support, we will have a bright future. Thank you very much.
Okay, thank you, PC. Thank you for your presentation. And we will leave all the discussion at the final part. And we will welcome Greg Raban from Australia. He's our past president of APWA. Greg, please.
Thank you very much. I hope you can hear me clearly. So this is on new concepts of assessment and management of carpal instability. So I'd like to acknowledge Simon McLean and also Melanie Masseria, who's been involved with some of this work. So when we look at scapholunate instability, we're used to using plain X-rays, but really maybe clenched fist views with dynamic assessment and moving assessment may be more appropriate. After all, we want to have an understanding of the kinematics, and it's not just a static instability. Really, this is an instability which is a dynamic phenomenon which is important for the functioning wrist. So if we look at this example here, where we're looking at an axial image of a 4D CT scan, we can see that the scaphoid is subluxating off the back. We can see some small osteophytes here, and we can see the obvious widening of the scapholunate interval. These images here are STL file creations from a 4D CT scan and comparing this to the cadaveric specimens. We've looked at the isometric point of the dorsal aspect of the scapholunate interval. I must admit, I always thought it was here, but it's a little bit more radial and probably reflects how the dorsal scapholunate ligament and the dorsal intercarpal ligament both provide stability to this interval. So we now change the position of our insertion points for our anchors for stabilization of scapholunate stability to make it more radial than what we'd done in the past. So if we look at the normal wrist versus scapholunate instability, we can obviously see there's some widening and we can see there's some dorsal translation. But we've seen a number of cases where it almost looks like the scaphoid and the lunate are completely dancing on the distal aspect of the radius. And this fits in line with a Telesnik type 2 injury, where you have the translocation of the ulna and you have the instability of the scaphoid and a wide diastasis. Clearly, this is a more difficult thing. So it's almost like this middle version has instability of the scaphoid, and this has instability of the scaphoid and of the lunate, so that it's clearly a much more complex injury. And we published some years ago an example of a patient who had a dorsal dislocation of the scaphoid. So this is another example. So really there's quite a spectrum here of scapholunate instability. It's not just a simple scapholunate instability injury. These images here represent proximity mapping of where the scaphoid and the radius, how close they are. And so, for example, this dark area here may represent less than 0.5 millimeter, and the light blue one will be, say, 2 millimeters. So if we have a look at this in real time, this is what with a patient moving the wrist, we're able to map out where the contact pressures are in the normal patient and with scapholunate instability. We can see that scapholunate instability, it tends to be more radial and often a bit more dorsal. It's interesting when we look at this example at the top, where although that there's some widening at the scapholunate interval, we can also see that when it comes together, there's pretty well total contact at that level. And finally, that the example I was just going to show just had some degenerative changes over the radial styloid. And we know from clinical experience that as soon as you get any narrowing of the radial styloid, that's abnormal. I'd like to share with you some work we've done on Kienbock's disease. And we can see how this lunate is widening. And we call this internal lunate instability. And it's interesting, we've identified a number of cases that also have an associated ulnar translocation of the carpus. If we look at this axial specimen, we can see that the lunate sits here with a short radial lunate ligament, and we've got the lunotriquetral and scapholunate ligaments. So we refer to this as intrinsic instability with Kienbock's disease. This is another example that's an interesting case where we can see this patient's got this fracture on the volar aspect of their lunate. And if we look at the axial image, we can see that this cortex is attempting to break and the ligaments remain attached to them. And ultimately, we're going to lead to an instability of that lunate. In comparison, when we look at this example with an avulsion of the volar lunate fragment and a larger piece which is now impinging, and we have examples where this fragment is completely locked and preventing movement of the carpus. So this is some of the spectrums that we've been able to identify. So with regard to Kienbock's disease, we think of it as having an intrinsic instability and also a type of extrinsic instability. So this is where the central column collapses after the fragmentation of the lunate. The radial column collapses as well. And that we end up getting this dorsal intercarpal ligament remains a little bit lax now, and the whole thing's collapsing down and lead to ulnar translocation of the carpus due to an extrinsic instability of the carpus. And this is the type of example we see here. We've obviously got this fragmentation of the scaphoid and of the lunate, sorry, but we've got this whole translocation of the carpus. And finally, we've been able to do some mapping of this is where the third metacarpal passes in radial to ulnar deviation of the wrist. And if we look at the motion of the scaphoid, we can see the scaphoid follows the capitate and the third metacarpal in ulnar deviation, but not in radial deviation. There's an outer plane motion of the amount of scaphoid motion. The scaphoid is actually going to a lot of flexion and then extension, leading to out of plane motion of the scaphoid. So we feel as though some of the concepts we've developed may be of value in the future, but we really haven't sorted the puzzle out yet. But I think we're a little bit closer, and now we have a method of being able to assess that. And finally, how do I approach it? Well, I think for the dynamic instabilities, I think Muthalen's technique is a good one. I think for the patient who has a static instability, we still like our tensionable suture anchors. And for those where the carpus is completely unstable, then I think Michael Sando's NFAB technique may be of value. Thank you very much. Can you hear that? Thank you.
Yes.
Wendell?
True.
Okay.
True. Can I be the chairman? Yeah.
Okay, please. Okay. The next speaker will be Toshi Nakamura, and he will talk about the new concept, treatment of stage 3 Kienbock's disease, free bone pack graft. Toshi, please.
Okay. Can you hear me?
Yes, I can hear you.
Yeah, I would like to talk about stage 3 and stage 4 Kienbock disease treatment with a radial shortening with bone pen fixation to the segmented lunate bone. Okay, so Kienbock disease is osteonecrosis of the lunate. In my opinion, that the cause of the Kienbock disease is coming from the blood supply disorders, which is like ischemic situation, then with the edematous situation with the lunate, and also microfracture due to the repetitive stress, which we call this one as a Carpenter disease. But to my understanding, that Kienbock disease is still mysterious disease to handle it and also diagnose it and treat. We actually have a Lichtman radiographic stages on that. Stage 1 is osteonecrotic, the lunate only found with an MRI. Stage 2 is osteonecrotic situation, which was found on the radiologic situation. Then stage 3A shows a segmentation of the lunate. Stage 3B is a carpal malalignment is obvious with a rotation of the scaphoid. And then in stage 4, we found the collapse of the lunate with a degenerative condition. And the Kirk-Watson calls it SNAC list. Then treatment option for adult Kienbock disease is normally the stage 1 is treated with conservative treatment. Stage 2 is, with Japanese normally adapt this one to radial shortening. Then some guys doing the vascular bone grafting or the capitate shortening. The Greg actually did describe in the last year in the Journal of Surgery. For stage 3A and stage 3B is rather difficult. Normally, vascular bone graft is applied to the stage 3A. In some describes that for 3B, a partial bone fusion or the proximal carpectomy was indicated. Then in stage 4 with Kienbock disease, then lunate excision with a tendon ball by a Carroll or PLC partial view fusion or total bone fusion was applied in this stage 4. Especially in the stage 3 and 3B, the lunate shows in segmentation, then a Carpal height reduces, then showing the rotatory rotation of the scaphoid and within the Carpal alignment. So treatment in this stage is quite difficult. Before 1999, that we actually did a tendon ball insertion by a Carroll technique, but we actually found that the Carpal malalignment and also that reduced grip power. Then we also that some patient added the STT joint fusion that can also show them the reduced range of motion with the wrist. So after 1990, since 1999, we actually did a radial shortening osteotomy with the fixation of the segmented lunate by a bone peg from the radius. Then in the stage 3B and 4 Kienbock disease, we applied a bridge type external fixator for 8 to 12 weeks to correct malalignment of the carpus and to maintain the lunate height. This is a case series, then 55 wrists in 54 cases were underwent this surgery. Then my case is a little bit different from others, that female is much dominant compared with the male. Then age average is 37 years from the 17 to 65 years. Then at least 2 years follow-up was applied. Then we found that Richtman's 3A stage in a 12 wrist, 3B in a 38, and then stage 4 in 5 wrist. So the technique was first we shortened the radius. Then some patient we applied an arthroscope to check the condition of the lunate segmentation. Then taking from the radius, we taken a bone peg. Then that was inserted into the lunate bone in an open fashion. Then in a stage 3B and 4, stage 3B and 4, bridge type external fixator was applied for 8 to 12 weeks to correct the malalignment of the lunate. You can see a bone peg here, and also bone peg here. Then we evaluated the vascular range of motion grip power recovery to the original work, Richtman functional evaluation, Donan's evaluation of the work abilities, modified Mayo wrist score, then X-ray and MRI findings, especially focus on the Carpal height ratio. Then a surgery was radial shortening with the bone peg fixation in 14 list. Then 41 list we applied an external fixator. Bus was reduced from 88 to 13. Range of motion was closely the same, relatively loss of flexion and increased extension. Grip was recovered from the 50% of intact to 90%. Then we found that we actually obtained 100% recovery rate. The occupation was heavy manual worker in 12, light manual worker in 11, housewife at 21. Then all of those are recovered to the original job. Then recovery period from the surgery was 11 to 24 weeks. Then Lichtman's criteria, we actually have 51 satisfactory result, 4 indicate non-satisfactory. Then we obtained 42 excellent, 13 good result in the Donan's criteria. However, that the modified May risk score obtained 5 excellent, 22 good, 1 fair, and 2 poor clinical results because of the range of motion, then grip power. Carpal height ratio showing in 34 wrist in 55 wrist. Then preoperatively, CHR is 0.48. Then recovered to the 0.56 in immediately post-operation. Then that post of 4 years and 2 years to 4 years showing 0.54. 33 wrist among the 55 wrist indicates a recovery of the MRI T1 signal. You can see the right side showing the recovery of the T1 signal in the same patient 3.3 years after the surgery. This case was a 50-year-old male office worker showing the stage 3A Kienbock disease, showing low signal intensity on the lunate with a segmentation of the lunate. Then we actually did this surgery with a shortening of the radius with the bone peg fixation. Then 2 years after operation, then the carpal height ratio is relatively smaller, but the grip strength was recovered to 14 kilogram to 40 kilogram. 19 years old porter, which is a light manual worker, showing a severe segmentation is on the lunate. Then this was categorized in a 3C by a Greg. Then we actually did a bone peg fixation. Then you can see a union of the segmentation of the lunate. Then grip power is recovered to the 22 kilogram to 40 kilogram. Carpal height ratio was recovered. However, that he shows a loss of flexion extension on the grip. So in discussion that we actually did a Carpal surgery with a tendon bone insertion. However, that we actually have many collapse of the carpus, reduced grip power. Then with an STT fusion, showing the severe restriction of the range of motion. Since 1997, that we actually did this surgery, then the compression surgery with radial shortening with a fixation of the fragmented lunate obtains relatively excellent clinical results. Then in stage 3B and 4, then bridge type external fixator was applied for 8 to 12 weeks to necessary to reduce malrotation of the corpus and to maintain the lunate height. That can show a little bit restriction with the flexion extension motion of the wrist. However, that clinical results were excellent. And also that you can see an union of the segmented lunate. If we do not apply an external fixator, then 2 years after surgery, lunate was collapsed. So in a stage 3 and 4, then we need an external fixator for this surgery. Carpal height ratios was recovered. So in summary, the technique and clinical outcome of the radial shortening with a bone peg fixation for segmented lunate in stage 3A, 3B, and 4 Kienbock disease. Then favorable clinical results with a radiological recovery of the collapsed lunate union of the segmentation are obtained. Thank you for your attention.
Thanks, Toshi, for your work. And I'd like to invite the next speaker, who is my co-chair, Wendong Su. He will talk about 3D printing assisted percutance fixation for scaphoid pathology. Wendong, please.
Okay, thank you. Can you see my slides?
Yes, I can see it.
Okay, so I will start, and we are talking about the scaphoid to fracture. So because we are a little bit late, I will skip to. So the PSF is very often used to cure the scaphoid fixation. And both dorsal and volar approach of the PSF of the scaphoid fracture has been described either using the standard volar approach or the trans-trapezial volar approach. The fixation procedure is a challenge. Usually, central place of the guide wire was not arch, was not. And often requires several times of drilling attempts with the help of the intraoperative CP. So, since the 3D printing technique has developed, many patient-specific guiding plates has been designed to perform in orthopedic surgery. It became precisely and easily. So, in these methods, the bone was exposed and used as a contact surface of the patient-specific guiding plate. In the PSF procedure, the scaphoid would not be exposed. However, the surrounding skin of the wrist with the proximal part of the thumb as a whole was a characteristic shape and could keep a relatively constant spatial location for the scaphoid, which could be used in the contact surface of the guiding plate. So we use the design two modifying techniques. One is for acute scaphoid fracture and for scaphoid union. This is a acute scaphoid fracture. 36-year-old male, right wrist 4 injury 5 days ago. So X-ray showed no obvious displacement of the scaphoid fracture. CT reconstruction showed a fracture line at the waist of the scaphoid. So this is the process of the guide plate designing as following. The acute scaphoid fracture case underwent CT scans and CT data were reconstructed. Plate was designed in a 3D software, printed, and then used in surgery. This is a CT data reconstruction procedure. Both the shape of the bone and the skin were illustrated, and an axis of guide wire was designed according to scaphoid and then combined with the skin. The guide plate was designed, which include a volar part, a dorsal part, and a tube for the guide wire. It's a video of the one-shot procedure. Before the procedure, standard wrist arthroscope was performed. And after that, the traction was removed. The guide plate, including the volar part, dorsal part, and tube, were put on. Then we use a KY drilled into the scaphoid very slowly to avoid KY bending. And then we check the guide wire position. We use the CP to see the guide wire's position is very good. Then this is the post-operative evaluation. The angle of the guide wire and the screw is very good. So this study was published in the Journal of Hand Surgery, American edition. Arthros ABG technique, PC Fu first advanced this technique, and in the first talk, he gave us a very briefly and global retrospective to see this technique has been widely used. So we can see in the patient with the scaphoid ununion, we start with the RCT study. It's group A is the number is 8, and the group B also the number is 8. We use the surgery is a 3D printing PSF plus ABG, and compare with the CB assistant the PSF plus ABG and do the evaluation. This is a male, 41 years old, and he can remember he got a twist injury 20 years ago, and so the wrist pain for 2 years and limitation for the ROM. MRI. This MRI showed the obvious scaphoid fracture with mini displacement. CT scan was performed to acquire 3D data. Besides the natural position, extension position is also scanned with the support of the short sprint. This position could make the trapezium move to the dorsal side. There is the design of the guide plate in a 3D scheme. After bone reconstruction of the plate, 3 axes of fixation was designed. According to the skin surface, a continuously guiding plate was designed. So this is the video for of the procedure. Arthroscope checking of the ligaments showed good quality. The TFCC is also okay. The ununion site of the scaphoid was found, and we used the 3D printing guide plate assist the KY drilling as was performed, which is similar with the case of the acute scaphoid fracture. Put on the plates and drawing a 3 KY slowly, and then the guide plate was put off. Fluoroscope was also used to check position of the KY. Under the arthroscope, all the tips of the 3 KY were found right in the proximal pole of the scaphoid. Then the KY was retroscrewed to the fracture site to facilitate the arthroscope removing of the bed bone, and then we use the ABG technique. After that, a small tube. Yes, this we and we also use the cover with a glue. So compare with the pre-operative CT scan, the scaphoid gets union in the post-operative 6 months. So this is RCT results. The results showed that the average bone operation time in group A was shorter than that in group B. The second outcome, including range of the motion, muscle strength, functional scoring in group A, is similar but slightly better than group B. Also, we published in the Journal of Orthopedic Translation with detailed information. So in conclusion, 3D printing is a quite fantastic tool to assist the surgeons in the treating both the acute scaphoid fracture and the scaphoid ununion. Finally, we have a very quick Hong Kong Huasan joint course and workshop of the wrist arthroscope every year in Shanghai. This year will be the 10th anniversary in November, and combined with APWA Congress. All of the wrist lovers are welcome to join the event. Thank you.
Thank you, Wendong, for the interesting paper. Now I'd like to invite the next speaker. Is Shanlin Chen, and he will talk about current concepts and my favorite procedure for scaphoid nonunion. Shanlin, please.
Okay. Good afternoon, everyone. It's my great honor to share some experiences in scaphoid nonunion. Because I noticed there are several speakers will introduce the method for scaphoid nonunion from the different view, and also because the time limitation. So this time I plan to introduce my preference for scaphoid nonunion only. And there are various bone graft methods stepped onto the historical stage successfully, which include materials bone graft and wedge bone graft with rigid fixation, and pedicle vascularized bone graft, such as 1,2 SSRE, or free vascularized bone graft, such as the bone graft from the medial femoral condyle, and also the bone graft under wrist arthroscopy. And all these methods still play their role well until today. And for myself, actually, I tried almost each of them during the past 20 years. For example, the pedicle vascularized bone graft and 1,2 SSRE, and the union rate over 90%. And this patient is a 45 years old male. You can see the bone defection is very clear here. So I used the 1,2 SSRE, and the X-ray after 2 years after treatment and bone graft, and the range of motion of the wrist joint is good enough. And this is a young guy. Also, I used the 1,2 SSRE. The range of motion after operation is totally acceptable. I also tried free vascularized bone graft from the medial femoral condyle for the refractory scaphoid nonunion, and also obtain a very good result after operation. And I tried bone graft under wrist arthroscopy for more than 15 cases. The union rate also, over 90%. I trust this is a very good method for scaphoid nonunion, especially at the proximal part of the scaphoid. Actually, each of the above methods could be used for all kinds of scaphoid nonunions. And all methods could provide patients with the union rate over 80%, according to the literatures, and over 90%, according to my experiences. So which one is my preferred method? As the ABG, wedge bone graft from Volar approach, perhaps a very traditional method. Why? Because I thought it is easy to perform compared with the other method, and with higher union rate always. For my 49 cases, the union rate is almost 98%. And use this method, we could expose the non-union area very easily and accurately, and it could correct the humpback deformity effectively if you think it is important. And also no need to worry about the bone graft, the vascularity of the bone graft exist or not after operation. So case one is a wrist scaphoid nonunion with humpback deformity. You can see after operation, the X-ray demonstration is nearly normal and correct the humpback deformity. Case two also is a scaphoid nonunion with humpback deformity. I performed fixation with 3 K-wires, And before operation, you can see the capitate and the lunate angle is increased. And after operation, it's nearly normal. So the range of motion, the function of the wrist after 3 years operation is very good. Case 3 is also used this method. 6 years after operation, the X-ray demonstration, the range of motion of the wrist. And case 4 is a 38-year-old female with a history of more than 13 years. And 10 years ago, she received a bone graft from the radial styloid in the local hospital, but the result was not good, and the non-union reoccurred. So we use this same technique. And after operation 2 years later, you can see the X-ray is very good. And the scores of the wrist after operation was also improved. Case 5 is a 28-year-old pianist. Because of scaphoid non-union, he couldn't play piano very well, so he felt very bad. And he received 2 times reconstruction in local hospital, but both procedures are failed finally. So I used this method and fixed the scaphoid non-union with leg screw. And 2 years after operation, the function, you can see the range of motion was very good. And the scores of the injury wrist was improved significantly after operation. And he felt very happy after he can play piano the same as before his injury. And he sent video to me. I'm also very happy too. And case 6 is a 19 years old young guy. And you can see the bone defection here, and also the fragmentic demonstration at the distal part of the scaphoid. So for this young guy, I always remove the distal part of the scaphoid. But this patient and his parents insist on to maintain the integrity of the scaphoid, help me to reconstruct the scaphoid. So I still use the same method. You can see 3 years after operation. And the X-ray was very good. The function of the wrist also very good. So discussions, both the scaphoid fracture and non-union are challenge problems for hand surgeons, and giving credit to a lot of great works. So we could understand the functional anatomy and the kinematics and kinetics better. So the treatment outcome was improved slowly and constantly after that. So there are many bone grafts methods in our hands, which could be divided into 2 types. The one is the ABG, the other is vascularized bone graft. So each of the methods has its own advantages and disadvantages. So for me, it seems that the key point for the treatment outcome depend much on the doctor's capability and the technical detail instead of the method itself. So we propose our strategy for scaphoid non-union. So you can choose different methods according to the types of the scaphoid non-union. So wedge bone graft from Volar approach with rigid fixation became my favorite procedures because it's an easier method with higher union rate and satisfaction rate always. The crucial points of this technique include: it could remove the ischemic or necrotic tissue completely. It could pack the cancellous bone to the cavity after debridement as adequately as possible. So we can using screw fixation as long as possible. So it doesn't mean the other procedures are excluded from my practice. So finally, please permit me to express my wholehearted thanks to some tutors who help me not only in the technical, but also the knowledge, a lot of knowledge in the field of wrist joint, and of course, including the scaphoid non-union. That is Joe Slade and PC Ho and Marcelin and Alexander Sheen. Thank you all. Thank you for your kind attention. Thank you.
Thank you, Xianlin, for your comprehensive review of your expertise on the scaphoid non-unions. So now we have a last speaker, Abhijit Wahegaonkar, and he will talk about salvage procedures for SNAC wrist. Abhijit, are you ready?
Yes, I am. Thank you very much for the opportunity to contribute to this webinar. And my task is to talk on salvage for SNAC wrist. So we all heard about these wonderful procedures to try and get the scaphoid to heal. But then every now and then we will come across cases where the scaphoid just refuses to heal, and we have the SNAC wrist if the treatment is not initiated. So the natural history of scaphoid non-union has very well been studied and described by many authors. And then we all know that because of the displacement, there is carpal instability and eventual arthritis. And this very nice paper by Lindström and Nystrom from Sweden showed that there is a 100% incidence of osteoarthritis about 10 to 17 years after the diagnosis of scaphoid non-union that is untreated. So again, this paper is a landmark paper, is cited very often. And then in about 93% of ununited fractures, you would see the incidence of OA 10 years down the line. And there's a very predictable pattern of evolution of arthritis, with 95% of the degenerative joint disease of the wrist having a periscaphoid pattern. And then the initial joint to be involved is the radioscaphoid joint, followed by the capitolunate joint. However, the radiolunate joint somehow seems to be spared. And then there's triscaphe arthritis. So the clinical presentation of patients with a SNAC wrist include pain, swelling, a restriction of movement. There may be a catching or a popping with loss of grip strength and crepitation. And then the stages of the SNAC wrist also are very well known to all of us, from stage 1 to stage 4. And 4 is when there is span arthritis. So this is a very typical presentation of an early SNAC wrist. You can see that there is an established non-union with very radiodense lines at the fracture non-union, and then the arthritic changes in the radioscaphoid joint. And of course, there is a DC deformity that is also seen because of the flexion of the scaphoid. And these are different stages of arthritis that one would see with SNAC wrist evolution. The goal of treatment of SNAC wrist is to provide pain relief while maintaining stability, strength, and mobility. And it could range from non-operative to operative movement management. And then, of course, the stage of the SNAC wrist is very important in determining what kind of treatment you would like to offer your patients. The general recommendations for stage 1 are either a styloid excision, which could be performed open and arthroscopic, or with bone graft and oral scaphoid. For the scaphoid non-union, stage 2 wrist denervation, scaphoid excision with mid-carpal fusion or a proximal row carpectomy, and stage 3 would have anything from a scaphoid excision to a partial wrist fusion or a total wrist fusion. We all know about the arthroscopic management of SNAC wrist, and my mentor, Professor Mathula, has come up with very innovative ideas about treating these conditions with an interposition suspension ligamentoplasty, along with the radial styloidectomy. And we'll hear about that shortly, I'm sure. But I'll not belabor too much on this. This is a radial styloidectomy. This is an example of a proximal row carpectomy, the principle of which is essentially to convert a hinge joint, a link joint, into a simple hinge joint. And of course, there are caveats to that, which I'm sure all of us are well versed with, and we all know the different procedures that one would like to resort to for treating these problems. Partial wrist fusion will comprise of either a 2-corner, 3-corner, or 4-corner fusion, depending upon the surgeon preference. Again, can be performed arthroscopic or open. We also have these different implants ranging from staples to headless compression screws and the spider plates, which will help in accomplishing the union or fusion. We all know the open procedures where there is a an extensive arthrotomy with scaphoid excision and a four-corner fusion, but we can use minimally invasive techniques while preserving the biology and providing the similar outcomes with minimally invasive techniques. This is again an example of a arthroscopy-assisted partial wrist fusion. The outcomes of these procedures have been well described in literature. The range of motion to be expected after radiocarpal fusion is about 40 to 45% of the opposite side, whereas with a midcarpal fusion, it is about 58 to 70% of the opposite side. None of these procedures are without their share of complications, which may range from non-union to incomplete pain relief, a progressive arthrosis, spin tract infection, osteomyelitis, nerve damage, and tendon rupture, which should be warned. The patient should be warned about these complications and these problems. The comparisons for proximal row carpectomy versus four-corner fusion again have been described in literature by Peter Stern and his group, and they are enlisted on the slide for your reference. I'll not belabor too much on this. They looked at their complications as well, and they found that provided that the procedure is performed in a proper indication with a proper technique, these complications can be minimized. Wrist denervation is also a procedure that can be offered for patients with SNAC wrist where there is good wrist mobility. On the dorsal aspect, you would denervate the articular branches of the posterior interosseous nerve, the radial sensory nerve, and the dorsal sensory branch of the ulnar nerve. And on the volar aspect, we have the anterior interosseous nerve, and you would strip the periosteum distal to the pronator quadratus and do a denervation that is complete. Here is a brief video, but I'll just run through this video to show you the different nerves that are being transected. This is the posterior interosseous nerve. We remove a segment of the pronator of the posterior interosseous nerve. The anterior interosseous nerve is then also addressed through the volar approach, and we have the sensory branches of the radial sensory nerve and the ulnar sensory nerve that are being denervated, and only the articular branches. This is the radial sensory nerve giving off articular branches to the wrist joint and the CMC joint as well. So you need to be very methodical and very meticulous when you're performing the neurectomy. Anteriorly, you want to be sure that the motor branches of the anterior interosseous nerve are preserved. So it is recommended that you do not resect any more than proximal about 2 centimeters from the wrist joint. The periosteum from the radius distal to the pronator quadratus is stripped off with electrocautery, and that would again give denervation effect to the wrist joint. So this is a brief video. And of course, then we have the option of performing a total wrist arthrodesis, which is a well-established and proven technique which provides reliable pain relief while providing a stable wrist joint. So in summary, non-operative treatment can be tried, but of course, with evolving arthritic changes, you would have to resort to some sort of a salvage procedure that has been described in this talk. Thank you very much for the opportunity to contribute, and any questions I'll be happy to take. Thank you.
Thank you, Abhijit. The final discussion will be moderated by Wendong. Wendong, please.
Okay, thank you. So, any question from the to the speakers?
May I ask a question?
Yeah, sure. Yeah, PC, please.
Thank you for all the speakers. A wonderful talk. I have some question for Toshi, because the method you present is very interesting and very different, but you can achieve a very good outcome. Just a few questions.
Yes.
For the lunate, do you do the debridement before you put in the bone pack, or you just pack the bone into the lunate?
The recent case is that I actually debride in arthroscopic fashion, then I put in the bone pack. But most of the cases, I just put in a bone pack without any debridement.
I see. So you think, because sometimes I believe the necrotic bone may cause pain itself. So that's why for me, I try to remove it. But maybe it's not necessary. So if you're
Yeah, that I think I agree with you that segmentation scenario can cause the pain, and also that amazingly that dead bone within a dead bone peg actually obtain the union of the segmentation in almost half of the cases.
Yeah, yeah.
That is quite interesting. That still, I think that the still necrotic lunate has an viability to reunite.
Yeah,
But if the situation is getting worse within the collapse of the carpus, that can also make a segmentation it's a little bit wider. So that is why that we put an external fixator to correct the malalignment.
Right. Yeah. Just one question is about the shortening. Because I see some case you show that the shortening seems to be quite minimal. So I don't know what is your principle, how much you're going to shorten the radius.
That is depending on how much the minus variant of the wrist. Then most of the cases has a neutral variance. So that is why I just cut it. Then I make a bone peg in a longitudinal fashion.
So if neutral outer neutral, you just cut very little and use it as a bone peg. So what is very little? 1 millimeter, 2 millimeter?
That is the most minimum one is only the braid width. Then there was a report from Argentina that a quadril compression was actually cutting the bone, actually increasing the blood supply to the lunate. And I still believe it. So that's why that I cut it.
Okay. So you're very actually how much bone do we cut? Cutting the process is already done.
So that is depending on the variance of the wrist of the patient.
Thank you. Yeah.
Very welcome.
I have a question to
gentlemen. So we should ask Liu Bo. Shall we continue discussing, or we have to close it and move to session 2?
Yes. So the time is running so quick. So I'm not sure after the webinar. Did you have any other things after the webinar?
No.
No. Okay. So when done properly, we can allow 1 or 2 last questions in this session. Then we proceed.
Okay. We still have. Okay. We have 2 questions. 2 last questions. Anybody? Yeah. You.
I have a question to Greg. Greg. Okay. You're just talk about widening between the scaphoid and triquetrum. Is it the cause of Kienbock or the results of Kienbock disease? What I mean by that is that if there is a ligament instability, such as the DIC tear, it may increase the pressure on the lunate. They may result in the Kienbock. So I just wonder if.
So what we've found is that quite a few of the fractures of the lunate are right adjacent to where the scapholunate ligament or lunotriquetral ligament would insert. So this makes it like not a true ligament injury, but it's effectively like a ligament injury. So it's like a scapholunate ligament injury, but without the scapholunate ligament being torn. So that's an intrinsic type of instability of the wrist, but also the whole wrist just tends to collapse down. And so we've seen some ulnar translocation of the carpus, and we think some of that's a little bit like the concepts of an extrinsic ligament injury. So it's an interesting phenomenon. I think we're still learning exactly how this fits together, but I'm confident about one thing, that it's more complex than than David Lippman taught us. And I think now we should be starting to think about Kienbock's disease as a type of carpal instability and not see it just as a bit of a fragmented lunate.
I totally agree with you that that might explain that some type of Kienbock's progress very rapidly, and those some other things are very slow. So that may difference comes from the ligament instability, I think.
Yes. Thank you.
Yep.
Okay, guys, we have 1 question. We can have 1 question, 1 more.
Ringlin?
There's a question from YouTube.
Anyone have a question? PC still. Yeah.
see that no other. I want to ask Wendong, your good self. Your technique is wonderful, but in case there's a displaced fracture or non-union, would your technique also apply? And if so, what is the tricks? How to cater for the displacement of the scaphoid?
It's a good question. Yes, actually, we choose this patient has no displacement or very small displacement. So otherwise, because the technique is not so mutual, so I do not want to make the surgery more difficult. So we choose the no displacement, only union, and easy to do the ABG technique.
Thank you.
Okay, so it's time, and so thank you all. We will close this session and go to the next session, and the moderator will be Dr. Shi and Andrew Chen.
Yes.
You are.
Yeah. Good afternoon. Yeah. The second section is the innovative procedure. Yeah. We have the 7 topic and 7 experts, including our guests and from the Europe. And Andrew will moderate relative each topic. I think each topic should be have the 7 minutes because the time is so tight. So to control your time. So the first topic is Professor Lee. You know that he is our Secretary General. He serves the Catholic University of Korea. His division of hand and upper extremity. Professor Lee, please.
Thank you for introducing me. I'll try to make it short, very short. So I'll talk about the 2-screw fixation technique for scaphoid fracture. Scaphoid fracture has been known to be difficult to treat because the patient sometimes neglect the injury as there is a very minimal pain. And the scaphoid is notorious for its scanty blood supply. And there are some issues with decision making when we choose the proper surgical options for this fracture. We all know that the classification system suggested by Dr. Herbert, type 2 A2 is incomplete fracture, B1 is oblique fracture, and B2 is a complete fracture pattern. Differentiating this fracture pattern, especially between A2 and B2, is very important, and as they look very similar in the radiographs and CT scans. So if there is any doubt in stability, I suggest to fix the fracture percutaneously. And we may need a stronger construct for the community fracture and all the non-union of the scaphoid. It has been well known that the central placement of the screw in the scaphoid increased fixation strength up to 40%. Another interesting research reported in the literature that the fixation stability is increased when the screw is placed perpendicular to the fracture rather than central placement in type B1 oblique fracture. To place the screw perpendicular to the fracture line in type B1 oblique fracture, the screw has to come from the dorsal side, as you can see in the figure C, the red line. And the green line indicates the screw direction from the volar side, which is not ideal for the oblique fracture. So if there is a B1 oblique fracture, it is recommended to place the screw via dorsal approach, as you can see in this CT scan, or the 2 screws from the volar side. Recently, a smaller headrest compression screws has been introduced, and putting 2 smaller screws become an option to increase the fixation strength of the scaphoid fracture. A biomechanical study published in 2018 revealed that the two-screw fixation construct is as strong as plate fixation and twice stronger than single-screw fixation construct. There's another biomechanical study showed that the two-screw fixation has the best rotational stability compared to the plate fixation or single-screw fixation construct. The biomechanical advantages of the two-screw fixation technique has been proved clinically in this case series. They achieved 100% union with two-screw compared to 86% union rate with the conventional single-screw fixation technique. This is one of my cases. A 26-year-old female came to my clinic with continuous pain on the anatomical snub box 12 weeks after initial injury. CT scan showed proximal to waist fracture of the scaphoid with cavitary bone defect. So I decided to put two screws from the Volar side to increase the fixation stability of the scaphoid non-union. Bone graft was not used in this case. Post-operative CT scan showed location and trajectory of the screws. I usually put one screw to the volar side of the scaphoid and put another screw to the dorsal side via trans-trapezial approach. These are final follow-up radiographs. Non-union was achieved uneventfully after 1 year surgery. Although it is difficult, two-screw fixation can be possible via dorsal approach for approximately 1/3 scaphoid fracture. So in conclusion, although A1 and A2 fracture can be treated conservatively, I recommend the percutaneous fixation for the A2 fracture if there is any doubt in stability of the fracture. And I recommend two-screw fixation for B1 oblique type fracture and the comminuted B2 fracture, as it is a more stronger construct compared to the single screw fixation. Thanks for your attention.
Well, thank you very much, Juyap, for the wonderful presentation. Next, I would like to introduce none other than our chairman of today's session, Dr. Liu Po, who will be talking on robot-assisted fixation for scaphoid fracture and fracture dislocation. To you, Liu Po.
Okay. Thank you, Andrew. Can you hear me?
Yeah, it's okay.
Yes, we can hear you.
Yeah. Yes. Okay, so time is very limited. My 7 minutes, we're talking about the robot-assisted fixation for scaphoid fracture or fracture dislocations. So we all know that the scaphoid percutaneous fixation of scaphoid fractures, I believe most of the speakers here actually think himself or herself is a magic result. Actually, is usually is not a very complicated procedure. Many of you may have experienced that you have a just one shoot is okay and quick procedure, but it is always true. Sometimes it's not the case. In the clinic, we continuously see the patient with a complication of the male practice of the fixation. And the complication rate for percutaneous fixation of a scaphoid fracture is as high as 30% from the literature. And our friend Scott Wolf from New York actually has put a sentence in his one of the papers that a seasoned hand surgeon can struggle to accurately place a percutaneous screw safely within the scaphoid. So it is. This is one of my patients. Actually, you can see multiple attempts tried and 106 fluoroscopy images taken to achieve an accurate placement of percutaneous screw fixation for a single patient. So why sometimes percutaneous fixation is not a piece of a cake? First of all, you know that the anatomy, the tortuous shape, and also the safe zone in the scaphoid when consider the diameter of the screw, actually the safe zone of the screw fixation is just 2 millimeters. And like in this case, it seems the screw is well in the bone, but actually when you scope in, you find a 2 millimeter error already lead to a disaster. And also, you cannot see the scaffold when you do a percutaneous approach, like the circus knife slurring without seeing anything. And also, we all know that scaffold is moving. So it's also, you know, the radial deviation or the deviation, flexion, extension, actually, each different position scaffold is in different 3D alignment. So how to make sure acute block always go around with you when you do a percutaneous approach? So of course, robotic surgery is a possible new solution for many of the procedures in orthopedic surgery. And we have robot for the soft tissue and defense in Europe. And also we designed a robot for the hard tissue in Beijing. So firstly, this kind of a robot was designed for the spine surgery or surgery for the large joint. However, the successful application of these big bones actually is not necessarily produce a successful procedure in a small bone, in the tiny bones. We all know that from big bone to tiny bone is never a simple zoom out. A lot of problem may occur. There would be lack of a peripheral hardware like the fingers of the robot, and also lack of the surgical planning software like the brain of the robot, and also a lot of problem like operating time, complex steps, and the radiation accuracy, etc. And our friend Dr. Shanlin Cheng actually has used this robot for in the hand surgery procedures like vascularized fibular grafting for AVN femur head. In this scenario, this robot is used also in a large bone. And we start the cadaveric study from 2016 to make sure the robot could be used for the tiny bones. This is our cadaver. You can see the simulation is the left and the rear movement of the robot on the right. And when you decide the right position, trajectory of the screw, and the robot may directly go to the specimen. And the accuracy was validated by cadaver study. And after that, we start to do the clinical study from 2018. You can find this is a real setting in the operating room. This is a robot. It is a stereostatic robot arm with 6 degrees of freedom. And the patient has a patient reference frame here, and the robot has the robot reference frame here. And you can see this is a optical tracking device. This is like the eyes of the robot. So the robot can see everything in the operating room and know the position of the robot arm and the position of the patient. And also we have the 3D fluoroscopy unit, like the 3D CT scan in the operating room. And we have the surgical planning workstation, when we drive, we have a navigation, we have a map for driving. And after the surgeon actually selects the right entry point and the trajectory of the screw, and the trajectory of the screw can be checked in 360 continuous sagittal, axial, and coronal plane to confirm the optimal 3D position of the screw. And then, what you need to do is just press a button, and the robot will do the job for you. The robot will go directly to the right position you'd like the robot to go, and you just follow the route of the robot and put in the screw. So our study is between January and September in 2018. Patients of fracture was undisplaced fracture, and the mean operating time was 14 minutes, including 18 minutes of setting and 22 minutes of operation. All patients has just a single guide wire insertion attempt. So you can see the outcome. So you can see actually the AP and lateral view, the position you select in the intraoperatively is exactly same as the post-op images. So this is our paper. This is a first reported clinical paper for scaphoid fracture with robot assistance. Also, this robot actually now has developed to a multi-functional device, which is can be used for all the location of the human skeleton. So more step forward. After the initial small success in the non-displaced fracture, we actually now are thinking about the displaced scaphoid fracture, peroneal fracture dislocation, subacute fracture or fracture non-union or partial wrist fusion, and so on. So this is an example. We use a arthroscopic assist reduction in the temporary fixation for transscaphoid peroneal dislocation. This kind of the grossly displaced fracture, actually, we all know that now we can use arthroscopy to help us to reduce the fracture minimally invasively, and then we temporarily hold the position, and then we can proceed to the robotic assist percutaneous fixation, both for the fracture, scaphoid fracture, as well as the dislocation of the carpal bones. So the robot can help you to allow you to accurately go to the right location and orientation you need with best biomechanical benefits. You can see the robot can help you to go to the right position, which you think is with the best biomedical benefits. So probably we should find something more interesting for surgeons' hand during the operation in the future. This is our dream, but we all know that sometimes the future is already coming. Thank you very much for your attention.
Thank you, Robo. Give us a so nice lecture. So I have invited the next speaker, Professor Mark. Yeah, he also service brings the Wales Hospital, Hong Kong, and he give today he give a title is the arthroscopic manager of scaphoid Mount Union. So, Dr. Mark, please.
Thank you. Thank you, Bolly and Andrew, for your invitation. So my topic will be on a computer-navigated treatment of scaphoid malunion and non-union. As we all know, there is bone resorption in scaphoid non-union, and indeed in the malunion situation, this malunion will result in the malalignment of the bone, and this affects the whole wrist as well. Although we know that the direction of the angulation of the bone is quite predictable with extension, supination, and translation of the proximal fragment, resulting in a lot of the time DC deformity, the amount of bone loss is not always predictable, and it has been estimated to be around 10% in most of the cases. However, the size and the shape is variable. So anatomical reduction may be difficult even with arthroscopic assistance or with the Lynch-Scheid maneuver. This is the closed technique of DC deformity correction using Lynch-Scheid maneuver. First, KY is driven into the lunate and the wrist is extended to correct the flexion deformity. However, this is correction in one plane with estimation of accuracy by fluoroscopy. There are open methods of 3D imaging guided reconstruction of the scaphoid using 3D printed PSI published in 2016. However, this looks like very extensive dissection and is quite nightmarish for us arthroscopic surgeons. Since the ABG was developed in 1997 by Dr. Ho, we have been thinking, is there a way to further improve the anatomical realignment in a non-union and malunion situation while keeping it minimally invasive? So we have developed a technique using computer-assisted preoperative planning in the first part, with intraoperative navigation and arthroscopic bone grafting in the second part. And actually both parts are equally important in the precise execution of this surgery. In the first part, we planet, we try to determine where the osteotomy should be and the bone defect. And this is done in the in our software called Mimics. And the second part involves pinning, and the aim is to pin the proximal scaphoid to the distal radius, making them as one unit, using titanium K-wires to reduce the amount of artifact. And in the second part, 2 K-wires are inserted into the distal pole. 3D image is acquired. This 3D image is then fused to the pre-op CT image within the software Mimics. And this is actually the most important part of the procedure and how it actually works. Because in this Mimics software, we try to extrapolate the 2 pins into the proximal pole while it is matched into the contralateral normal side. So we assume that in the normal side, these 2 pins will then be extrapolated into the proximal pole, thus aiming to achieve the normal anatomy. So then navigation is done, and the pins are driven into the what is thought, or planned to be the correct position. And actually during the navigation, the probe confirms that the accuracy is actually quite acceptable. And this is the result of the 3D model. And in 2 cadavers, we found that the accuracy is within 0.5 millimeters, so it's still acceptable. So this is the first patient, 19-year-old boy, basketball team player, school team player. He had injury in September and presented to us in mid-November. And by December, the bone has already healed in malalignment with CL angle 37 degrees, SL angle 90 degrees. This is pre-op. The range is quite good, but there is persistent dorsal-radial wrist pain. And this is the humpback deformity. So within Mimics, we tried to determine the osteotomy site, and the difference in height was estimated to be 5.5 millimeters from the contralateral side. This is the bone graft site. And actually, within arthroscopy, we could not easily identify the fracture site because it has already healed, but this took some time to do. The first part was to do the Lynchite maneuver, correct the DC deformity, and then pin the scaphoid between the distal radius and the capitate. And osteotomy was done under navigation. And the 2 pins were, this is the osteotome, which was also navigation guided. The osteotomy was made and the 2 pins were driven into the proximal pole. And note that I tried to make the 2 pins as proximal as possible to preserve more space for putting bone graft in. And this is the intraoperative arthroscopic video. The malunion was taken down. Fibrous tissue was removed. The bone was debrided as in the usual way in ABG. Graft packing was done, and finally fibrin glue was applied. And this was 2 weeks post-op, at which the radial lunate pin was removed. At 12 weeks, all the K-wires were removed. At 7 months, the bone has healed quite well. The alignment is quite acceptable. And comparing to the pre-op, both the CL and SL angle has improved. This is at 1 year, 4 months. And he was able to return to the basketball court and shoot again with his wrist. Another case, 30-year-old young man, fush injury while playing soccer. He injured his wrist in October and presented to us the next year, 6 months down the road. So again, a quite severe DC deformity. And in fact, because of the malalignment, there was some carpal instability as well at the SL region. There was stiffness of his right wrist. And this DC deformity was actually irreducible. Even at maximum flexion, the lunate could only be brought just to neutral position. So breakdown of the scar tissue was needed within the arthroscopy. So again, pinning of the scaphoid between the capitate and the radius, and this is a radial lunate pin to perform the Lynchite maneuver, and this is the tracker in the distal radial area. This is how the bone was corrected in the software with reduction of the collapse, the flexion deformity, and the pronation deformity. Again, the two KYs were extrapolated into the proximal fragment, like so. The osteotomy was done by navigation guidance, and the two pins were, this is the gap after the osteotomy was performed, and the two pins were driven in to the proximal pole, bone graft put in, and the final pin was inserted. This was at 6 months after radial lunate pin was removed. I actually converted the KY into a screw to have earlier aggressive rehabilitation and range of motion exercises. So the DC deformity was well reduced in this case compared with the pre-op image. So as conclusion, non-unions and malunions can affect the whole wrist. Computer navigation can help you to permit a minimal invasive approach to correction, tell you where to do the osteotomy, and avoid overstuffing or underfilling of the scaphoid to achieve anatomical correction. And you need to have a computer whiz or be a computer whiz yourself to use Mimics or similar kind of computer software to have this osteotomy correction. And this is the workflow of the whole surgery. Thank you.
Thank you very much, Dr. Mack, for the very interesting way of dealing with scaphoid non-unions, especially using technology. Thank you so much for the talk.
Thanks, Andrew.
Next, I would like to welcome Dr. Marianne Brunner, our IWAS colleague from Lyon in France. She'll be giving us an evaluation of hamate tip replacement for proximal scaphoid non-union. Marianne, to you.
Yes, good morning, everyone. It's a great pleasure to be here. Can you see my screen and can you hear me?
Yes,
yes, okay.
Okay.
No problem.
Hello. Thank you very much for the invitation, and I would like to acknowledge my co-author from Mayo Clinic. So my topic is proximal hamate graft for proximal scaphoid reconstruction. First of all, let's have a look to this case. He's an 18-year-old patient. You can see of course, the non-union of the proximal pole of the scaphoid. This is an avascular non-union and a fragmented proximal pole. So what are the options for this kind of young patient? These are the different options we already know and which had been described. And I will discuss a new option, which is the proximal hamate graft to reconstruct the proximal pole of the scaphoid when the scaphoid is fragmented. The first case was described by Dr. El Hassan and Dr. Cracker from Mayo Clinic. And in this same young patient, they were able to achieve union and a good functional result with no pain at 3 years follow-up. The first question for this technique will be, is there any bad effect on the carpal kinematics after removing the proximal hamate? That's why the same team performed this study, and they showed that there were no difference in carpal kinematics after removing the proximal hamate. So the second question was, does the proximal hamate graft to reconstruct the proximal pole of the scaphoid restore native carpal kinematics? And that's why my topic, we used 8 fresh frozen mid-forearm cadaver specimens. All were lunate Vegas type 1, with of course no arthritis and no scapholunate abnormalities. We use specific pins to fix the sensor to the different carpal bones we wanted to evaluate. Then we loaded the wrist flexors and extensors tendon, and we put the specimen into the specific frame, which were able to perform a cyclical motion. This is a wrist simulator. Then with optoelectronic sensors, we use the Murray phase tracking 3D motion to measure the different carpal bone motions. After performing the scaphoid fracture, we reconstruct the proximal pole of the scaphoid using the proximal hamate. we harvest through a dorsal sparing approach. We harvest the proximal hamate. Then, as you can see, we pay attention to also harvest the volar capito-hamate ligament. Then the proximal hamate was flipped at 180 degrees to match the shape of the proximal pole of the scaphoid. This is the screen after the screw fixation. And then we were able to repair the scapholunate ligament using the volar capito-hamate ligament. We evaluated the intact wrist, then after performing the proximal pole fracture, and finally after the hamate autograft. We measure the lunocapitate and the scapholunate motion in wrist flexion extension and radio-ulnar deviation. This is the statistical analysis. And now let's have a look to the result. First of all, there was no significant changes between the three conditions, considering the proximal row kinematics that occurs in flexion extension. But in radial ulnar deviation, the kinematics of the lunate and capitate was significantly modified after the creation of the proximal pole fracture, while the hamate graft was able to restore carpal kinematics. The most notable changes in carpal kinematics occurs in the scapholunate flexion extension and scapholunate radial ulnar deviation along the wrist radio-ulnar axis. As you can see in these conditions, after performing the proximal pole fracture, there was a significant change across the entire arc of the wrist radial ulnar deviation axis. These changes is consistent with previous studies. But after performing the graft, you can see that the graft was able to reproduce the same condition as the intact wrist. Of course, there are some limits of this technique because it is a non-vascularized graft, but also some advantages because it is the same donor site and you can reconstruct the scapholunate ligament by the same surgery. One of the main concerns could be the match between the proximal hamate and the proximal pole of the scaphoid. For that, we have these two studies. The first one from Dr. Wu in 2018, and they compared proximal pole of the scaphoid and proximal hamate, and they reported a match in almost 70% cases. And a more recent study from Dr. Kaka and the team, and they also observed in 10 patients that the maximum distance between the two bones after matching them with a CT scan was 4.1 millimeter. And there is now some recent clinical series, a small one, of course, it is about 4 patients, and you can see that they achieve union in all patients at 14 months follow-up, despite a mean delay after injury of 7 years and a proximal pole scaphoid non-union with avascular necrosis. So to conclude, the proximal hamate graft, the proximal pole of the scaphoid can restore carpal kinematics and can be an alternative for fragmented proximal pole scaphoid non-union. Thank you very much, and please, we will be happy to see you in the virtual Lion Race course in September.
Thank you very much, Mario. It's a nice idea and a nice lecture. I invite next speaker is expert. Professor Wang is also come from Taiwan. He serves in Taipei Veterinary General Hospital. He's the director of the Division of Hand Surgery. He gave a talk about the arthroscopic treatment for proximal scaphoid non-union. Professor Wang, please.
Thank you very much. And my topic is about the scapholunate screw fixation and arthroscopic bone graft for the proximal pole non-union of scaphoid. There are some challenging cases of scaphoid non-union.
Yeah, Professor Wang, do you share your screen?
Oh, yeah. Okay. Great. Can you see that?
Yeah, it's okay.
There are some challenging cases of scaphoid non-union, especially AVN and proximal pole and the distal pole fracture and failed previous surgery with screw retention. Today, our topic is about the scaphoid proximal pole non-union. There are some debates, scope or open, fascularized bone graft or non-fascular bone graft, a heavy screw or KY, a retrograde or antegrade. So we choose scope and the non-fascular bone graft and the heavy screw, scapholunate screw fixation for treatment of scaphoid proximal pole non-union. Just like a Russell technique, the technique or the fixation is the same, just like a sandwich compression. This is from the case, 21 case is from my mentor, Dr. Xu. The type 1 and the type 2 scaphoid non-union meet our criteria because the proximal pole of non-union, the bone fragment is very tiny. So under arthroscope, we deploy the fracture site and we use the temporary KY fixation to correct the DC. And under arthroscope, we fill the gap with the bone graft and use the screw to fix the scapholunate. So in 21 case, there are 2 case failure. I failed to healing and finally go to full corner fusion. But the other case has good results. In the case 1, it's a 32 female. It's a scaphoid proximal pole union with species for even months. You can see it's a proximal pole union over here and with species deformity. So under arthroscope, we do the debrided bone graft and use the APWA screw to fix the scapholunate. And we also do the radial styloidectomy. After 1 year of follow-up, the fracture site already healed. This is the case 2, scaphoid proximal pole non-union. It's a 19-year-old female. It's a scaphoid with a species for 8 months. So how to fix vascular bone graft or non-vascular bone graft? Screw or KY because the fragment is very small. So one antegrade or retrograde. We also need to reduce the lunate for DC deformity. So under the arthroscope, we debride the fracture site and fill the bone graft and use the APWA screw to fix the scapholunate. After 6 months, the fracture site already healed, so we remove the screw. The range of motion is very good. So after 3 years, this lady was very satisfied with her beautiful wrist. It's a 28 and his scaphoid proximal pole fracture after plating non-union. It was noted after removal for implant. Initially, he used the immediate plate to fix, but non-union happened. So we removed the implant. And the same, we use the arthroscope to debride the fracture site and use the bone graft to fill the gap and use the screw to fix scapholunate. After 6 months, we find that the fracture site already healed. But we suggest patient to remove the screw, but the patient didn't want to have surgery anymore. The discussion. So this is from my mentor, Dr. Wolf's paper. He said the proximal pole non-union is very likely have impaired vascularity, but infarction is rare. So he said the surgical key is debridement and the non-vascularized bone graft. And he said vascularized bone graft is still then required. And Dr. Wolf also has a paper about use the antegrade screw fixation for the proximal pole scaphoid. He finds that he has 2 cases of isogenic fracture due to the stress stresser. So this technique for screw fixation for scapholunate for proximal pole non-union has some advantage because it is quite rigid fixation and higher union rate and better range of motion, especially dorsiflexion. And we can avoid the secondary fracture of the proximal pole. And if this case have some associated scapholunate injury like GAST 1 or GAST 2, we can also fix because maybe the one screw maybe maybe solve two problems. We suggest remove the screw to prevent the windshield wiper effect. So the key for the scaphoid lunate screw fixation is we use the arthroscopic bring and bone graft, and this is a one-shot operation. It's a technique demanding. Maybe in the future we can use a robot technique to have a quick, more accurate one shot. The screw need to the guide pin need to cross scap and lunate center. So we center to center, and we need to approach scaphoid lunate double cortex. The screw may be longer as possible to reach the arm and corner. And if the patient has the case have a disc deformity, the lunate need to reduce. So we are very lucky in this case. This series are published in BMC, a journal of BMC, and the other we also published in the journal Hand Surgery. So special thanks to my mentors for my fellowship training overseas, Professor Maturin and Professor Wolf and Professor Chen Xiangyin and Professor Xi and Dr. P.C. Ho. We will, I and Dr. Xu will organize APWA in 2024 in Taipei. We welcome all the APWA friends to join us to enjoy the Grand Hotel and the mountain climbing and bridge cycling and the LPGA golf course. Thank you very much.
Thank you very much, Dr. Wang. Enjoy your talk very much on this very innovative technique of yours. Next, I would like to invite none other than Professor Christophe Martulan, who does not need introduction. Everybody knows him. He's a founder of EWAS. He's a precursor of the now IWAS, and he's also one of the distinguished honorary members for this APWA. So we'd like to welcome him with pleasure to talk on arthroscopic interposition tendon arthroplasty for SNAC wrist. Christophe.
Hello, my friend. I'm really happy to be here with you. I am currently in Corsica, and my internet is not very stable, so I hope everything will be okay. So I hope to see you rapidly in Korea, maybe at the beginning in November, maybe in Shanghai in November. And I remind you that we continue the face-to-face course to Strasbourg, and I hope to see most of you next November course and next February course. So I would like to discuss about the arthroscopic interposition arthroplasty. You know that in SNAC there is different stage, and the classical treatment are very aggressive in SNAC 2 and SNAC 3. It's why we propose the arthroscopic technique, which we consider that very simple, is a styloidectomy, the simple styloidectomy as usual. But after that, we remove the cortical bone of the scaphoid fossa of the radius, hoping the creation of bleeding, and with this bleeding, natural soft tissue arthroplasty. Then after that, we put an absorbable anchor into the radius styloid, like that, and we harvest the palmaris longus, which is the right perfect tendon for the arthroplasty. We use the technique I described for stabilize, not repair. Of course, you imagine at this stage is not, we don't have any possibility to repair the scaphoid lunate. We will try to stabilize the gap between the scaphoid and the lunate with the technique. And for that, we use another anchor in the proximal pole, because at this stage, classically, there is no remnant tissue in a scaphoid, in order to stabilize the capsule and the scaphoid lunate. Then the current technique is to use one strip dorsal as an hemi-interposition technique described by Michel Levedou, and one strip volar intra-articular ulnar to the long radial lunate ligament. You see the principle of the technique here. The tendon pass from the 1-2 portal to the 3-4. Then behind the dorsal capsule and in front of the extensor tendon. We enter into the 6R portal and we retrieve in the 1-2. For the second, the Volar strip, exactly the same technique. And at the end, we create a mattress under the scaphoid. So you see the midterm result, retrospective study, the salvage procedure. Of course, we operated 72 patients, majority of male. The age is, the average age is 60 years old, and the non-fracture in 61, non-trauma, excuse me, in 61 cases. We have a majority of SNAC 2, and we tried to operate SNAC 3, but the result is not very good. So you see, it is a classical indication, very beautiful SNAC 2 with a big gap, but the rest of the joint is safe. And here, the placement of the anchor, you see the tendon into the joint, and you see after 6 years, of course, is not perfect, but we have created a space between the scaphoid and the lunate, and we stabilize the scapholunate dissociation. So it means that the patient continue to have a not so perfect range of motion, but is very happy because it's painless. The average follow-up is almost 6 years now, and you see that according to the pain, it's very interesting. Of course, the range of motion is not perfect, and the strength is better, but not very, very incredible. We published the result with Margareta Ariani in arthroscopy with the first longer follow-up with more than 2 years. And you see this case, preoperative, post-operative, and you see the creation of a big space. We had temporary inflammatory reaction in 10 cases at the beginning of our experience because we used the PLA. We believed at this period that the PLA could be a solution, simplest for the patient, but in fact, it doesn't work, and it creates, you see, 9 inflammatory reaction on 40 cases, so it's very bad, and we abandoned this technique. We have 6 failures. You see this case, preoperative, and I was not so happy, but it was not so bad. And after 5 months, it's a big failure. So we have 2 failures in SNAC 2 and 4 in SNAC 3. We, of course, the cosmetical result is very good. So it is my first patient. He's 60 years old, former trial motocross champion, current coach of European champion. And you see, after 12 years of follow-up, he had a good, a curious aspect. I agree with you, but the nature is stronger than us, and he found a solution. And he sent me his picture. Now he's 75 years old, and he continued to perform the motocross, and he told me that he had some minor pain after 3 hours of technique. So the arthroscopic interposition in SNAC 2 is a salvage procedure, of course. It seems to be not a so bad operation as a classical tendon interposition. And it was always curious to know that when we return for different reasons, we found the normal tendon inside the joint. So probably the environment of the synovial protects the tendon, but it's very convenient for the patient. The palmaris longus is the right implant. Of course, we need a longer follow-up, more than 10 years to consider this operation as a valid salvage option. Thank you very much, and I hope to see you rapidly.
Thank you, Professor Madurin. So nice lecture. The last topic is arthroscopic measure of the SNAC. I have to invite the Inva, the old friend. He is the head of the Department of Plastic Hand Surgeon, Hamburg Hospital, Germany. He is the past president of FISH. Eva.
Yes, hi, hello. Thanks to invite me. I'm happy to be here. And I will start my presentation. It's okay for you? You can see it?
Yeah, it's okay.
Yes, okay.
The computer is running now, right? Okay, it's okay.
It's okay now?
Yeah, it's okay.
Greetings from IBAS. So arthroscopic management for SNAC mostly has already said. So we can use it for diagnostic and staging of SNAC to check also the ligamented status and see if we have already some osteoarthritis and where it is already gone. For treatment option, we have arthroscopic synovectomy and denervation if we want so, a debridement and radial styloidectomy, arthroscopic assisted partial wrist fusion, or arthroscopic assisted proximal row capectomy. So the partial wrist fusion or proximal row capectomies or salvage procedures are mostly in SLAC and SNAC. In my hand, more in SLAC than in SNAC, but now we want to talk about the SNAC. So what is the goal? We want to maintain range of motion and function with an acceptable pain. There is also some papers for arthroscopic proximal row capectomy, but they are not that much. For most of us who are going in open procedure, Riccardo Lucchetti promote an Palmer approach. He said this promote early rehabilitation and faster recovery. This is a paper about arthroscopic proximal row. What I'm doing is a synovectomy, arthroscopic cutting of ligaments as much as possible with the help of beaver blade or sharp tip of the needle, 2 small open approaches for resection of the first row, dorsal ulnar remove, for the dorsal ulnar remove lunate and fragment in the first step, and a Palmer for remove this scaphoid. Okay, now my computer don't. Yes, this is a case of Kienbock disease, but you also can use it in the SNAC. Here you can see the CT scan with a fractured lunate, and here you can see the cutting with the needle, the sharp tip of the needle of SL ligament, LT ligament, and then you can remove the 3 bones like you can see upside. And this is the result. This is another patient with a SNAC, and you can see the functional results, 6 months post-op with acceptable scars, in another case here. So this is my way to go for proximal row capectomy. And this is what we can do. For sure, in stage 3, we only can go for partial or total wrist fusion. We can achieve very good results with that, and we can have it in open and arthroscopic surgery, but for that we need a solid bony fusion and a good reduction. And it depends not on the resection of the pin. So we need to open up the bone, maintain a good bone stock and bone graft to fill up the surfaces if we need so, and a stable osteosynthesis. We can use an open procedure flower plate or screw wires, and for sure an arthroscopic assisted. We cannot use plates. For the good reduction, we need the DC to remove the DC deformity. It depends also on the type of lunate for the radial ulnar translation, and I prefer a slightly overcorrection of DC. It gets more extension of the wrist and no overcorrection of ulnar translation. So this is what we can expect. It's 30/30 extension flexion, better functional is 40/20, and a reduction of the pain. And Palmer already told us that a 13/15 is enough for functional wrist motion. And a comparison of dart throwers motion or regarding RSL fusion, four-corner fusion, and proximal row capectomy gives no differences in these 3 types. This is here we can look for the lunate type 1 or 2, and we can see a lot of people have a slight type 2 and no overcorrected. If we put the lunate directly on the capitate, we get a more stiff wrist. This is a case, and here was after 4-corner fusion. And for sure, you can do a denervation as well. In open procedures, most of us do it in the same time. And in arthroscopic procedure, you don't do it. And I don't see in arthroscopic or open procedures a difference for pain at rest or at work. So it doesn't depend on the pin resection. For the arthroscopic procedure, you need a resection of the mid-carpal joint and a removal of the scaphoid with a burr or for a mini open approach, arthroscopic transplantation of the bone graft, and percutaneous screwing. So this is my technique I do. I go very fast, and you can find it in multiple applications. Resection MC arthroscopic with the oval bore, it helps it go faster. Here you can see it on the right side. It's a bigger tip, so you can go very fast for that. And you need some bleeding for sure in the bones that you can heal afterwards. And then you go for an excision of the scaphoid. It's what I'm doing from a radiopulmar approach. Here you can see the scaphoid, and meanwhile you do the reduction. Your scrub nurse can prepare the scaphoid for the reduction, and temporal transfixation go in the maximal flexion of the wrist and ulnar adduction, so you can reduce the lunate very well. Here's preparing the bone graft, put a ulnar catheter in the scaphoid hole to prevent bone chips falling down there. Here's the bone chips are coming in. And like Michelle proposed us to fill these tubes, pre-fill them, then the cancellous bone grafting is very, very fast. It takes maybe 5 minutes that you have all the graft in. Then you can re-advance the second key wire, open tourniquet, and do the final osteosynthesis, what can be the most difficult part of the technique. Of the procedure. So for the osteosynthesis, you can go with key wires or screws. The key wires from the screws are very soft, and so I go with 1.4. If he's sitting perfect, replace them with a smaller one for the screw to lower screw over. If not perfect but good enough, leave it and go for next one. So you can go for key wires or screws, and you can mix also screws and key wires. Here you can see a case of mixture of them, or here only key wires. I do like it goes the easiest way. Sometimes the capitate is very curved and it becomes difficult to put the screws. Here you can find the details from the technique. Post-op 6 weeks cast or orthesis, and then beginning of active motion out of the cast 2 or 3 weeks post-op. CT scan in every patient after 6 weeks for bony healing, if dubbed for the osteosynthesis directly post-op. Here is a result 4 weeks post-op. And there's a result 6 weeks post-op, 6 months post-op, very good functional results and no scars or very few scars. Now the patient, he had an denervation elsewhere before. 6 months post-op. So it's not that easy procedure, especially in the first time. You have some complications. In my own series, 4 in the first 20 patients and 1 in the other 30 cases. And this was reported also from a group from Latvia. 3 of 6 patients required reoperation. So it's technically demanding and has a learning curve. We need to take care for the osteosynthesis not to protrude in the carpal tunnel. This is not visible in the OR if you have not a 3D CT in the OR. I don't have, so be very careful. Attention to the PT joint as well, but this you can check more easily. Key wire or screw, I don't see any differences. Even in this paper, there was the benefit from the plates, but for me, key wires makes the same result. So why doing an arthroscopic is technical demanding. Our time is a bit longer than in open procedure. We have a better bony healing and a better range of motion, and the early beginning of exercise is maybe not important, but the quality for that is good. So less post-op swelling and pain for the people and better bony healing. So regarding the quality, I'm for the arthroscopic partial wrist arthrodesis. It's APWA. Thanks a lot und vielen Dank.
Thank you very much, Eva. Well, it was a wonderful talk. I would like now to open the floor to questions for the faculties and speakers, if any.
Can I ask a question?
Yes, Julian.
Okay, to Marianne.
Yes.
Hello. It was a very interesting idea, but my concern is that you know, there is a helical motion between hamate and triquetrum, which leads to the volar subluxation of the triquetrum during the ulnar deviation. It's the role of the hamate. So how large can we get the fragment without hampering this motion?
Yes, thank you for the question. Yet, of course, this is the main concern about this technique, and that's why there was this previous kinematic study. Actually, we harvest almost 4 to 5 millimeter of the proximal hamate. This was sometimes pretty big when you harvest this, and we did not observe kinematical changes. But of course, we probably need a further study, and we probably also need to study the loading and not only the kinematics. But so far, there was no kinematics changes. But thank you for the question.
Thank you.
Can I ask a question, Eva? That was a very nice talk. You covered a lot there. You talked about using the sharp needles to cut the capsule off the bone. Can you go through that in a bit more detail, how you do that? Because that must be an important step to be able to do an arthroscopic proximal row carpectomy. So you must get the alignment of that right. And can you just explain a bit more how you might do that?
Yes, thanks for the question. At the beginning, I tried to use a beaver plate or 11 plate, but the problem is to enter in the joint safely and come back, not to cut the tendons and so on. And so with the tip of the needle, this is very sharp, and you also can curb it. So it means you can also on the dorsal side, and you can enter very safely. And it's I do a lot of percutaneous needle fasciotomy and dipitran, and maybe the idea is coming from this point. And these needles are very sharp, and you can take several ones. So you can cut the SL and LT ligament. This is easy because it's just in front of your 3, 4, and 6R portal. And to go on the dorsal side, you can curb it. If you want to cut on the palmar side as well, you need a palmar portal. But when you go then for the open removal, you can cut this at this moment as well. For the scaphoid, you can cut the ST ligaments because you're radiopalmar. And for the dorsal side, it's a little bit more tricky, but it's also possible with a normal life then.
Yeah, question?
Yes, PC.
Same for Eva. Thank you very much for bringing the needle. It's another instrument I like very much. I did also use a lot of needle. My question is about the PLC again. The rehabilitation. I want to know what is your rehabilitation plan after your arthroscopic PLC, usually?
What is my what?
Rehabilitation. So do you immobilize the wrist or do you allow early mobilization? So
no.
what?
I do. They have just a kind of orthesis for the first, I will say, 2 weeks or 3 weeks. It depends on the pain. You need also, like an open procedure, some time that the other soft tissues can contract a little bit because it's too movable at the first moment. But they can be in active motion as soon as they feel comfortable with it.
Well, absolutely agree, because in fact, I just want to echo this idea. When I performed the PLC some years ago, I also with a wish that I hope it can be different from an open procedure, because of the minimally invasive technique, you don't open the skin. Theoretically, you can start the motion much earlier, because most people doing an open PLC perhaps will start motion, say, after 6 weeks or so, before the capsule form. But later on, I found this is not applicable. Because as you mentioned, after remove the first row, the too much laxity for the soft tissue. If I start the motion too early, in fact, the patient will experience more pain during the process. So much that I have to slow down the rehabilitation, I have to remobilize the patient again. So after some case, my conclusion that even you can perform a arthroscopic PLC, you may not reach the purpose of reaching the goal of early mobilization, because the nature would not allow you to do so. You still need to have the ligament to stiffen up. Perhaps you take around 6 to 8 weeks to do so before you can actually start motion. So I think for this reason, it becomes less attraction for me to do a PLC with the arthroscopy.
Yes, to do it in real arthroscopy, I think it's too much time consuming to go with a burr for it. So this is I would say a mixture. There's a minimal invasive approach because you need make less scarring on the on the soft tendons around, soft tissues around, sorry.
Sure. I have a question for Wang Junpan and of course my co-chair Wei Tian. This is regarding your procedure. It's almost like doing a bone grafting of the non-union site and Russell procedure or SLAM procedure by Jeff Yao and Melvin Rosenwasser. How do you actually ensure that you actually fire at the correct axis between the scaphoid and the lunate? Because usually the complications have been described for a SLAM or a Russell procedure about these screws not at the right axis and causing future complications. Any tips and tricks?
My mentor, Professor Xu, can answer for you.
Yeah, it's because we are middle cover joint arthroscope. We can monitor how about the scaphoid lunate joint alignment. So when we put the bone graft around the fracture site, actually we also see the scaphoid lunate joint. So we can maintain the congruity. And after that, we temporary fixation and we apply the screw with a Russell method that can continue maintain the congruity of the scaphoid lunate joint.
Thank you.
Again, one follow-up question. I always think it's difficult to remove the screw after 6 months. How can you find a hole? It's quite traumatic to find the hole.
Maybe a little bit lucky. Have to find a hole. Yeah.
I have an answer. It is the modification of the arthroscopic bone grafting I propose for the proximal pole, placing car wires from scaphoid to lunate. When I use the technique of Melvin Rosenwasser to put a screw between the scaphoid and the lunate, the trick I had to find the screw after is to put a car wire inside the screw and to cut it. After that, you find really easily the screw.
I see.
Yeah, so you leave the K wire. You leave the K wire with the screw.
Well, the K wire inside the screw. Very just 1-2 millimeter, but you feel with the tip of your finger, and you can.
That's a very good trick. Thank you so much.
Not so difficult. Yeah. Do you have time to discussion?
If any more questions from the speaker or from any question from the YouTube? I'm not sure.
Liu Po, can I ask you a question? Is there extra cost for patients undergoing a robot procedure in your country?
Yes, we're planning. Yeah, actually, for the we're talking about the screw removal from the coppers. So actually, we also use the robot to help us to find the exact way to remove the screw. So we have tried a couple of cases, which is we save the surgeon a lot of time, a lot of X-ray exposure. I think it's also an alternative for this procedure.
Have you taught the robot to reduce the fracture yet? Have you taught the robot to reduce the fracture?
No,
that's the hard bit.
Yeah. That's a future. That we are doing the research on how robot can help us to reduce the fracture as well. So yes, but I think it's a removal of screw is also an indication for the robot. Yeah.
In fact, I want to comment. I actually echo very much to Paul. Removal of screw in the scaphoid can be one of the most difficult surgery in the wrist surgery. I recall one of my cases. I used 3 hours to remove the pre-wrist. Somebody placed a bloody screw inside the scaphoid, but I have to remove it because it's non-healing. So I have to remove, but it takes so much time. So it can be very difficult. So that's why whenever whoever want to place a screw in the scaphoid, you have to make sure that you have a way to remove it subsequently. That's actually related to one question to Julio, because you mentioned the double screw technique, and it seems to me you always go through the trapezium as you propose. But I would say that would that be difficult to remove afterward? And also, would that be produce some sort of STT joint arthritis? Because if you routinely do that, would that be one concern?
Okay. Actually, I've never experienced the removing the screws after all surgery, so I cannot answer your question. But the second thing is the scapulotrapezial arthritis. There is an article in the literature that although there are the trapezial approach, there is a not significant arthritic changes after several years. So I have never experienced, I never have any problems with the scapulotrapezial joint with my procedures.
Surgeon never say never.
Yeah, right. Let's see.
We have a question from the YouTube from Rebecca Lim. So her question is about what about using degeneratable screws? I believe this question is also for Junpei and Ritian.
Yeah.
How about the absorbable screw?
Yeah, well, it's available in Taiwan, but still now I have no any experience about that. Have anyone have used such a screw?
Yeah, I've used it for 2 cases. Yeah, I've experienced the magnesium screw. Yeah, that's right. I've tried. Quite successful, but it takes about nine months for the screw to disappear.
Andrew, so you use this screw for scaphoid fracture?
Yeah, for scaphoid fracture as well as scaphoid non-union. Yep.
Yeah. So what is the material for the screw?
Magnesium.
Magnesium. Okay.
And in how many months does it?
About 9 months before the screw starts to denature and disappear.
Okay.
You have no resection, bone dissolution problems, because in Germany they showed us some not that encouraging results, and they are more or less disappearing from the market here in Germany.
I had quite a traumatic experience, because the first 6 months it looks as though the fracture was not united. Then lo and behold, at 9 months, when the screw started to disappear, then you see the fracture heal. So for the first 6 months, there was actually some gas, some hydrogen gas being released. So you look as though there's some lucency there. So it actually obscures the bone healing process. Yeah.
Introducing this absorbable screw is mechanically sufficient for scaphoid fracture.
I think if it's fixed properly, you allow the fracture to heal within the correct timing. Of course, it should heal. But of course, if it's going to be delayed union, that's where the problem may actually potentially arise. Then the strength of the screw may actually deteriorate. Yeah.
The thing that worries me about all these things like magnesium screws is we don't know where the magnesium goes. If it goes in the liver or into the brain or into the heart muscle. I just think stainless steel is pretty good. We've been using it for a while. We know that's safe. Eva, have you got a comment on that? Because I know that a lot of that came from Germany. Have they done all the studies on the safety? Is there any issues with that?
To be honest, I don't know. Yes, there are some issues, but I'm not sure if there are some papers. But I know from the market and they are more or less gone, because more of the resorption of the bone, there was at least in the small bones, it looks not that encouraging. I'm not sure if they are still available, but the publicity they have done is very much reduced now, so it seems to be no more there. But I can have a look at that.
Okay. Okay, if we have no more questions, probably every speaker, we just open our camera and take a group picture. Gloria, can you help us to take a group picture?
Yes. Great.
Okay, I can help. Please turn on your video.
Epasai.
Okay.
Epasai. Cheese. Okay.
Thank you. Well done.
Okay. So.
Okay, finish.
Okay.
Thank you.
Thanks, Joe.
Let's welcome our President Toshi Nakamura to ending this session.
Yeah, thank you very much for joining this third webinar of the Asia Pacific Research Association. I actually enjoyed the great talks, which was widely spread in the Carpal pathologies. Then I think that everyone understand this one very well, more deeply, and that we're gonna meet in that next November in Shanghai and also in a hybrid style. So see you next time.
Thank you so much for the organization. It was
Well done.
perfect.
See you in November.
Thank you,
Our
Lupo.
friend from
Wonderful.
Europe, from IWAS. Thank you, the friend from Europe, IWAS. Thank you very much.
Thank you.
Bye-bye.
Yeah.
Bye.
See you
Welcome
again.
you all
Bye.
in November.
Bye.
November.
Bye.
November.
Thank you, everybody. Take care. Stay safe. Bye-bye.
Bye.
Stay safe. Bye bye.
Thank you.